Thank you very much, Dr. Abdelli. We have planned to have a panel discussion, so we'll get all the speakers at the end of the morning. So thank you for that excellent presentation. I'd like to now invite Dr. Mushira Inani from Riyadh for the next presentation. So look forward to your presentation. Thank you, Mushira.
Good morning, ladies and gentlemen. It's my pleasure to be here in my second town, Manama, and I'd like to thank the organizing committee, Bahrain Medical Society, and in particular, Dr. Manaf. Today, I will be speaking on what is the baseline stewardship activities that is happening in the Gulf. You heard a lot of data on resistance and on whether gram-negative or gram-positive, so I'm not going to repeat what you heard over the past day and a half. So the outline will be giving you some background on healthcare system in GCC countries. Then we'll talk about the result of antimicrobial stewardship that has been conducted in 2013, and another study which was recently completed in 2014 on antibiotic prescribing in emergency department in Saudi Arabia, Saudi-wide, and then conclusion and recommendation. So if you look at the Gulf states map, you can see Saudi Arabia. Saudi Arabia, of course, is the largest on the map, followed by Sultanate of Oman, then United Arab Emirates, Kuwait, Bahrain, and Qatar. Some of the demographic indicators for the region on the column on the left. Showing you the area in kilometers square, and the circles showing the total population. Again, these data were a bit old, 2008 and 2009. You can see 25 million Saudi Arabia population as of 2009 with an area of 2 million kilometers square, compared to Bahrain, which is a very small, compare Saudi Arabia with a population of 1 million people. These are some other healthcare indicators, human resources. You can see the physicians, the first column. Do I have a laser pointer? Or just okay. Is it working? It's not working, it's fine. Okay, you can see here the physicians ratio or rate per 10,000 population in different Gulf countries. If we focus on the red rectangle, which is Saudi Arabia, you can find that we have 21.8 physician per 10,000 population. Regarding pharmacists, 5.9 per 10,000. For healthcare related personnel, 23.5, hospital beds, 22, compared to 19 in United Arab Emirates and Bahrain. Primary healthcare centers was 0.8 for Saudi Arabia, and it was 1.4 in Qatar, so it's exceeding us in this aspect. Hospital beds, we have the largest, as we're the biggest country, so we have 244 Ministry of Health hospitals, 39 other government hospital, and 125 private sectors. And all in all, the health centers were 2,037 health centers in Saudi Arabia as of 2009. So this just gives you a background on the infrastructure and human and material resources. This report by McKinsey & Company showing the projected increase in treatment demand in GCC by 2025. And you can see here whether communicable or non-communicable diseases. We have a great, we have a great demand, and increased, the average is 240% projected increase in treatment demand. So we will be in a bad shape by 225 if we did not work hard to improve the healthcare and improve the way we practice medicine. Again, this graph shows the projected demand for hospital beds in Gulf countries by 2025. and you can see the cumulative rate is 140% increase in demand for hospital beds. So all of these challenges, in addition to the resistance that we heard, it's a drive for us to work hard and find solutions. So what I'm going to do now, I will be discussing the results of the antimicrobial stewardship survey that was conducted among the GCC countries. The rationale beyond doing it was, of course, because of misuse of antibiotics in our region and worldwide. It's very prominent, accounting for 50% of prescribing is inappropriate. Gulf countries also are facing challenges, as you heard, resistance in gram-negative, in carbapenem, in gram-positives, and we don't really have very, very few regional guidelines, and we don't have policies for restricting antibiotic without prescription as an outpatient, so any person can go to a pharmacy and get any antibiotic he'd like to use. And there are limited assessment of stewardship strategies across hospital in our area. So I tried to find any literature. I could not find studies done to assess these programs. So the objective was of the current study is to describe the prevalence and characteristics of antimicrobial stewardship in GCC and explore opportunities and overcome barriers to effective implementation. It was a survey or a questionnaire, web-based survey tool was disseminated to healthcare workers in GCC countries during the period of January to March 2013. The study has been approved by the IRB of King Fahd Medical City, and the survey tool was posted on a website, a professional website called Dr. KSA, targeting 2,000 health professionals. In addition, 20 personalized emails were sent for infectious disease colleagues. Some of them are here today with us and then for more, data. So the target population were infectious disease physicians, pharmacists, microbiologists, other physicians, administrators with interest or experience in antimicrobial policies. In fact, the data we collected includes demographics of the hospitals they work in and demographics of the participants. So what is their job title, what's their role in the hospital? It's very similar to the international survey that has been done by Professor Dilip and Professor, I think the chair, or Philip also, yeah. It's very similar questions. And we asked also if those centers who have stewardship in place, we asked what strategies they use and what outcome measures and what were the barriers. So what did we get out of this survey? 47 healthcare professionals responded from 4 GCC states. This is a very small number, although we targeted 2,000, but the response rate was low. But at least we got 47 responses, and only 4 GCC states, the majority from Saudi Arabia, and few from Bahrain, Qatar, UAE, and Oman. Unfortunately, Qatar and Kuwait, there is no response, so we did not get representation. Number of hospital inpatient beds in these centers, mostly tertiary care teaching hospital of a capacity of 200 to 400 beds. These were the major contributing centers. When we asked them whether they do have stewardship in place, 61.7 said yes. And this is really amazing number. And I'm not 100% sure if they interpret stewardship as just antibiotic management or control or consultation. But at least 61% they said yes. Like about 1/3 they don't know or they don't have. Electronic prescribing was quoted by the majority of the participants, 70%. And regarding funding, 75% also said they were not funded for this program, so it wasn't available. These are the top strategies or objectives, the objectives of stewardship that were quoted among the participants. The top three were improving outcome, patient's outcome, minimizing or stabilizing resistance, and the third was reducing cost. And these are reasonably, I mean, it's going with the objectives of IDSA, British guidelines, and these are very important objectives. Those centers who are having or planning to have stewardship, we asked them whether they are doing rounds to monitor antibiotics, and they said 50% yeah, they are doing antimicrobial stewardship round, and mostly in ICU. So ICU was the target for the stewardship round. This graph shows some barriers that facing stewardship team, and it's in fact multiple factors, but lack of personnel and funding was prominent, in addition to multiple factors like lack of awareness from administration, obstruction from prescribers. So it's multiple factors that constitute a barrier. Interestingly, that most centers that participated, they do have a drug and therapeutic committee, antimicrobial stewardship committee, and these two are very important they can play important role in stewardship. However, they do not have, or very few, like 3% only, they have standards for antimicrobial stewardship. 5% they do have policy or code of practice, and 3% have published annual report. So the documentation wise, it's not there, but actually they are doing some sort of antibiotic management. Again, as Hail just mentioned in his presentation and in another survey by MOH, these were hospitals not only related to MOH, more than 80% they do restrict antibiotics. So it was kingdom-wide plus Bahrain and United Arab Emirates. The restriction policy seems to be very famous. Okay, they 63% perform antimicrobial audit, and antimicrobial monitoring was also quoted by the majority of participants. So they do have some sort of antimicrobial stewardship. The guidelines that they do have includes first choice antibiotics, antimicrobial dosing, treatment of specific infections. It's variable percentage, but the surgical prophylaxis is 19%. I'm sure it might be higher, like the survey that was shown by Hail showed more than 70%. They apply the surgical prophylaxis, but in this survey it's 19%. And so they do have multiple ways of guidelines for antibiotic guidelines. This is an important slide which shows the impact of their program. So we asked them, what is your outcome of the stewardship program in your place, in your institution? And the top three was improving clinical outcome, 70%, minimizing or stabilizing resistance in 72%, reducing cost in 44%. I think these are significant impacts that they noticed. I'm not sure, again, the way they measured it, but this was their response. So what are the limitations of our study? We know that it's a questionnaire and it's a self-reporting way of, so we're not 100% sure about the validity. So, and it's a small sample size, it's only 47. However, it gives us some background information, at least in Saudi Arabia. Also, the lack of representation from Qatar and Kuwait, and very few from Bahrain and United Arab Emirates may make the results difficult to generalize outside Saudi Arabia. But it gives us some information about what is happening in the grounds. So these findings suggest a golden opportunity to enhance existing antimicrobial stewardship program and spreading implementation through sharing best practices and developing regional guidelines across GCC states. Through strong commitment and leadership of Ministry of Health in GCC, they should improve manpower and funding of such program for quality and patient care. Do I have time or? Okay, because I have another shorter study. Okay. Okay, this is another study that's been led by Dr. Ali Al-Amrani and the group. I was a co-investigator with him, and it's been accepted in ICMID as a poster. It shows the prescribing pattern of antimicrobials in emergency department in Saudi Arabia, and it was widespread from 8 centers. In fact, the objective to understand the pattern of prescribing in emergency department and to identify priorities for stewardship interventions. It was prospective observational studies for patients admitted to any 8 study sites. So there were 8 hospitals across Kingdom Saudi Arabia that participated. Patients were followed for 2 weeks, and the inclusion criteria, they should be on antibiotic for at least 24 hours or more, whether IV or orally. After exclusion, we got a total of 216 patients who met the inclusion criteria, and we found that 373 antimicrobial agents from 22 different WHO classes were prescribed on day 1 of admission. 85% were administered intravenously. And this is the graph which summarizes the finding. The bar diagram shows the commonest infections encountered and what are the classes of antibiotic used. You can see here respiratory tract infection is number 1, followed by intra-abdominal and skin and soft tissue infection. And a good proportion of patients in the column before the last, you can see good proportion of patients receiving antibiotic with no evidence of bacterial infection. Cephalosporins were the highest prescribed classes of antibiotics. Another observation was only 38% of prescribing was compliant with local guidelines. It's just above a third consistent with guidelines, and the choice of initial antimicrobial regimen was usually made by a junior physician and was not really changed by more senior. Blood culture were drawn from only 21% of patients, and chest X-ray in 66%. By 72 hours, I think this will be the last slide, by 72 hours after hospital admission, there was 12% they had de-escalation, 11% they had escalated the treatment, 4% switched from intravenous to oral, and only 2.4% of the original choices made by junior were changed by senior. So it's almost nil. So it just tells us that we have problems with compliance with the guidelines, and it's inadequate. We have the majority of patients seeking emergency department treatment. They are receiving antibiotic unnecessarily, and our priorities will be in training and education of junior doctors to encourage more involvement from senior physicians in antimicrobial stewardship. I think the take-home message will be we need, as a GCC countries, to collaborate to implement stewardship across our hospitals with specific process and outcome measures. It's also, I'm recommending to mandate stewardship through a national or legislation or accreditation boards, as well as having a surveillance for healthcare-associated infection and resistance and tracking of consumption of antibiotic for benchmarking. And thank you very much. I will leave you with some photos from our stewardship conference in Riyadh. Thank you.